For colorectal cancer, somebody who was born in 1990 now has quadrupled the risk of developing rectal cancer and over double the risk of developing colon cancer compared to a similarly aged person who was born in 1950.
It seems more and more young people are being diagnosed with cancer. This is a trend that has made its way out of the clinic and into popular culture. If you watched the last season of The Pit, you'll no doubt moved by the story of Roxy Hamler, a young mother who had terminal lung cancer and was struggling to balance her own well-being with her desire to be there for her family. It was a really heartbreaking situation, and of course, while that character was a work of fiction, her story is all too real. Cancer diagnosis rates are on the rise among younger people, in particular colorectal cancer. So what's behind this rise, and what can we do about it? Hi, I'm Derek Angus, a physician and senior editor at JAMA, and you're listening to Healthy Dialogue. Today, I'm having a conversation with Kimmie Ng, the founding director of the Young-Onset Colorectal Cancer Center at Dana-Farber Cancer Institute in Boston. She's a professor of medicine at Harvard Medical School and an associate editor at JAMA. And together with Kimmie, I'm also chatting with Ilana Richman, an assistant professor at the Yale School of Medicine, an assistant editor at JAMA Internal Medicine, and a researcher who focuses on cancer screening. We're going to try to focus on two key questions. First, how steep and how serious is the rise in cancer among younger people? And second, what can we as individuals, as physicians, and as a broader society do to slow it down? Welcome, Kimmie and Ilana.
Thank you for having me.
Thank you. So, Kimmie, let's just start with the obvious question. It certainly seems like more young people are being diagnosed with cancer. Do the data actually bear that out?
I think you're right. Anecdotally, for years now, we have been seeing more and more young patients coming in diagnosed with often very advanced stages of cancer where they have actually no obvious risk factors, no family history or genetic predisposition to developing cancer. And it was very curious as to why this was happening. I think it was with the publication of a paper in 2017 that really solidified and confirmed that these were, in actuality, real trends that we are seeing across the US and actually around the world, where the incidence of colorectal cancer, for example, has been increasing by about 2% per year ever since the mid-1990s in both men and women.
If the incidence is going up, are more people dying of cancer? Or, obviously over these last few decades, we've completely changed the way we screen for cancer. We've got more sensitive tests. We're promoting greater awareness. Is this rising incidence just a good thing, just the fact that we're catching more people? Or is there actually something going on with the biology within society?
I think it depends on which cancer type you're talking about. So I am a gastrointestinal medical oncologist and predominantly treat colorectal cancer. So I'll maybe talk about colorectal cancer as an example. So we do not think that it is just overdiagnosis or incidental detection when it comes to the increasing rates of colorectal cancer in people under the age of 50. And that is because actually in people over the age of 50 who have been screened, the rates are actually going down and mortality is decreasing as well. However, this is not true for the young patients with colorectal cancer, where it's not just incidence that has been increasing, but mortality rates are increasing as well. And in fact, the newest statistics show that colorectal cancer is now the leading cause of cancer-related death in men and women combined who are under the age of 50.
Well, that's quite scary. We'll definitely want to talk more about colorectal cancer, but Ilana, I'm wondering, what trends are we seeing in other cancers?
This pattern of rising incidence among younger adults has been observed across a number of cancer types, including breast, pancreatic, even some hematologic cancers like multiple myeloma, kidney cancer, thyroid. And I think what's interesting about this observation is that the pattern of incidence and mortality is not uniform. So colorectal cancer is an example where we've seen this rise in both incidence and mortality among younger adults, which suggests that the cancers that we're finding are important to detect and to treat and are probably not a sign of purely overdiagnosis or just detecting more cancer. But the pattern that we see for other kinds of cancers is not the same. So, for example, in breast cancer among younger adults and other kinds of cancer, we see this divergence where incidence is rising, but mortality is actually falling, which suggests that overdiagnosis may be at play. It's also possible that treatments in those other cancers have improved, and that's another explanation for those divergent patterns. But I think the key thing is that the pattern is, in the case of colorectal cancer, suggestive of the idea that this is not merely about overdetection.
And just so I can sort of place this in an overall context, most of the time when we're young, we're not expecting to get ill, and we're certainly not expecting to die. I think from the age of about 20 to 50, the odds of dying in any given year are pretty low. And in the United States, the cumulative chance of dying in those 30 years is between 3 and 5%. So with that as a background, how big is the contribution of death from cancer in young people?
It turns out it's about 8% of deaths among people 22 to mid-40s are attributable to cancer. And of course, only a portion of those are from colorectal cancer. But I would argue, and Kimmie maybe can speak to this too, that cancer among younger adults is really uniquely important in the sense that, first of all, there are many years of life lost among people who die. And second of all, among people who live, their life course is changed by that experience. And I don't know if you want to add to that as somebody who spends most of your time in this world.
Yeah, no, it's absolutely correct. Although it's difficult to receive a cancer diagnosis no matter what age you are, people in their 20s, 30s, and 40s are definitely at a different stage in their life where they may be thinking about starting a family. They're in the midst of their education or careers. There's a lot of disruption in those areas of life, and that leads to financial implications, financial toxicity, and it really is quite a different diagnosis to contend with when you're dealing with a younger person.
Do you think it's also true that we have a mental model of what should make you sick when you're young? And while car accidents are terrible, we think of them as very rare, and we probably erroneously think that we can largely avoid them. Or I think that, I don't know that that's actually true, but we're hoping that it won't happen to us and that we have some agency. And certainly people can think, well, if I never take opioids, I can't possibly die of an opioid overdose. So even though that's a gross oversimplification, one could imagine that one goes through life thinking that one can protect oneself against some of those other risks. But then what's particularly scary about the idea of a cancer diagnosis is it's just hard to square the story, like the story in the pit of that woman who was dying at 42, who had apparently got metastatic lung cancer in her 30s while raising young kids. And I think it's hard to watch it and not think, there, but for the grace of God, go I. That's just like an incredibly scary story.
Yeah, and I think what adds to that is that so many of these young patients diagnosed with cancer were previously completely healthy. They were active, they were eating healthy diets, they didn't have a family history, they didn't have a genetic condition that would predispose them. And it's just completely unexpected for an otherwise healthy young person like that to then be diagnosed with often advanced stages of cancer. So I think that adds to the high levels of distress and anxiety that often plague our young patients with cancer as they go through their cancer experience.
So if the rise in early onset cancer isn't genetic, why is this happening? There are certainly plenty of theories. Scroll through social media for a few minutes and you'll hear about the dangers of certain diets, of lifestyles, exposures, and more. But I wanted to understand, what do we know and what do we still need to learn?
If you look at the epidemiologic trends that have been documented in the literature, These trends follow what we call a birth cohort effect, where the increase is really varying by generation. And as an example of that, for colorectal cancer, somebody who was born in 1990 now has quadrupled the risk of developing rectal cancer and over double the risk of developing colon cancer compared to a similarly aged person who was born in 1950. So when we see this generational trend in incidence rate increases, that usually suggests environmental factors that have recently come on the scene or emerged as the likely explanation for why these cancers are increasing in young people.
I totally agree. A fourfold increase, that's staggering. Maybe I could go further. It doesn't even feel like natural environmental change, like a fourfold change across a single generation. That feels almost like, have we done something to the environment we live in? What is it?
It's like the biggest question of our time right now. What is causing the rising rates of young onset cancer? And while I think that there has been a lot out there about diets and lifestyles, and I do think those things contribute to the rising rates, I don't think those are the entire explanation. Because as I mentioned, so many of our patients that we care for in clinic are perfectly healthy and they're not obese and they exercise a lot. So we do think there might be something else going on. And there's just a lot of active research going on to try to figure out what those risk factors are.
Right. So if this were a conversation about cardiovascular risk factors and lifestyle, I think to your point, you would say that there are individual lifestyle choices that changes someone's risk. I think you're suggesting that there's nothing obvious about the person that presents with cancer in comparison to many other friends and family members that they all went to high school with. It's not as if they engaged in a set of lifestyle habits that would make you immediately go, aha, you better be careful.
Yeah, many of them do not have these risk factors. Now, that being said, the published studies do suggest there are links between obesity rates and incidence of young onset cancer. There has been a study recently published in JAMA Oncology that showed an association between higher intake of ultra-processed foods, for example, and a higher risk of developing colon polyps when you're under the age of 50. So those things definitely do contribute, but I don't think they're necessarily the whole answer. And certainly for all the different types of cancers that are rising in young people, I don't know that these factors have been thoroughly studied in all these cancer types, and there certainly are probably novel environmental exposures that may be contributing as well.
So, Ilana, it seems to me across my entire career, maybe I'm showing my age here, I feel like there's been all sorts of stories about environmental exposures, lifestyle habits that could change not necessarily the onset of young cancer, but of any cancer. At one point, it was too much burnt toast, too much caffeine. Alcohol has been in and out of guideline statements as to either a moderate or a no risk or a high risk. It's definitely so with some cancers, but across my entire career, I feel like I have heard about these studies. And of course, these are inherently difficult studies to conduct, are they not, to identify a strong causal link.
Yeah, absolutely. I mean, I think identifying particularly dietary risk factors is always challenging because diet is so highly correlated with all kinds of other health-related behaviors. But a few things consistently come up in the literature that seem to be sort of lifestyle risk factors, including consumption of red meats. There's more data around sugar-sweetened beverages and cured meats. And of course, these things are prevalent in the American diet and are difficult to avoid in some ways. They're sort of ubiquitous. So those are, I think, challenging risk factors in the sense that they're everywhere and hard to avoid. In other ways, I think our diet is probably better than it was 30 or 40 years ago. We eat less red meat as a country. School lunch has changed. There have been lots of efforts to improve the diet. And so, to Kimmie's point, like it's hard to actually know, thinking about what are the secular trends or what are the large environmental trends over time that could explain this? Not entirely obvious.
And presumably, regardless of what these things are, I mean, we still need to think about how it's actually happening. I presume we're somehow changing our body's ability to effectively, for example, scavenge for poorly behaving cells. Our cells divide all the time. I'm going to get too far out over my skis here, so I'm the least qualified oncologist on this call. But if I were to say that cancer results from things like imperfect repair, DNA repair, cells mutate, they start to divide, and of course our immune system, we have a variety of mechanisms in health to sort of weed out those bad cells and keep everything suppressed. And presumably these cancers in young people are because something is then defective in these repair and or scavenging processes, or we're actually increasing the mutation rate. So either we've all accidentally become irradiated, the Earth flew closer to the sun and no one noticed, and we're all getting bathed, our Geiger counters have all gone up. So do we have any working theories? If it's not that we're actually having more mutations, is that there's somehow a defect in scavenging for those?
I think you're absolutely right on target with how to think about this. The hypothesis and the model that has been put out there is that it is environmental exposures, and that does encompass kind of novel toxins and pollutants, as well as diets, as well as lifestyles. It's likely that they're probably influencing directly processes that may lead to cancer, but also perhaps changing our microbiome, which is the trillions of microorganisms that live in all of our guts, and also our immune systems, to your point, such that they're maybe not as able to fight off or detect early cancer cells and prevent them from, developing into full-blown cancer. And I think what's even more challenging about how difficult it is to study this is that we do think it is environmental exposures, diets, lifestyles happening to children, happening early in life, whether you're an infant, whether you're even in utero, whether you're a child or an adolescent, that is changing something in our biology and in our bodies that then makes us more susceptible to develop cancer at a younger age than historically we have seen.
That's fascinating. So yes, as you allude to, our immune system, the one we're born with, develops rapidly over the first few years. As you pointed out, it starts developing in utero, and it develops in part through the things it's exposed to. And one of the biggest things our immune system is exposed to is our microbiome. That effectively trains our immune system, helps us work out what's self versus non-self, how active, overactive, and so forth to be. So you're thinking, and I guess this might be appealing because a lot of the rises in colorectal cancer in particular, and the biggest portion of our microbiome is in our gut, that perhaps this cohort effect has been because people are growing up today with a different microbiome from the microbiome that we grew up with decades ago. Is that?
That is part of the theory for why this might be happening. And actually, a recent result for the first time potentially links the microbiome in early life to an increased risk of developing colorectal cancer under the age of 50, where a large study of 11 countries found that there's a distinct change in patterns of DNA mutations that are much more common in younger patients under the age of 40 than people who are 70 years of age or older with colorectal cancer. And it is thought that this pattern of mutations is due to a bug in the microbiome. So, a lot more research needs to be done to really see whether there is a cause and effect here. But it is very intriguing that a bug in the microbiome now has been linked potentially to a higher risk of colorectal cancer in young people.
Yes. I can already imagine the almost interminable debate that will go on if it turns out that we have accidentally distorted our microbiome in a way that's disadvantageous for this risk of young cancer. Then we will move into the very murky policy world of what do we do to try to recalibrate everyone's microbiome on the planet, and whether that has implications for all the antibiotics that big ag uses in livestock. I mean, I almost don't want to go there.
It's true. It's really hard to think about how we're going to intervene on it if that really is the cause. And if you can imagine that it's microbiome changes in babies or children, intervening in the very, very young is also very hard. So it's an uphill climb.
An uphill climb indeed. As I thought about what an incredible challenge it would be to recalibrate the entire planet's microbiome, that turns out to be the best solution for this trend. I couldn't help but hope for some simpler solutions. So I wanted to know what the field is thinking about practical ways we can mitigate this problem now, even if we don't yet fully understand the cause.
I think one of the cool things about colorectal cancer screening is that it's not just screening, but it's also prevention. So the modalities we use, in particular, colonoscopy can identify early stage colorectal cancers, but also precancerous polyps. And by removing those polyps, we can reduce the risk of latter colorectal cancer. And that's actually also true for stool-based testing, which is less sensitive for precancerous polyps, but nonetheless detects a good proportion of them. So we have a lot of tools actually to take on the challenge of colorectal cancer. The U.S. Preventive Services Task Force lowered the screening age from 50 to 45 in 2021, and that was considered a big move. And it was in response to concern about rising incidence and mortality in this age group.
So as someone who doesn't work in the oncology space, you often look at the way we're responding to cancers with a certain degree of amazement. So it was almost unbelievable to imagine that we would do colonoscopies on the entire country. And now, of course, we're talking about doing lung CT scans on almost the entire country, or maybe whole body CT scans. But that's a huge lift. I mean, most of us, when we went to medical school, preventive strategies were things that cost almost nothing. And so you could do it to everyone. It would like sort of general education, et cetera. The idea of a colonoscopy as a preventive test. I mean, I don't know what you can get the cost of a colonoscopy down to, but it's still it's an invasive test. It takes a lot of time. You need a place to do it. You need a bunch of highly trained people. It's kind of amazing that we decided we were a wealthy enough country that we could just start doing colonoscopies on the entire country to do early intervention to try to decrease the incidence of colon cancer. And so once I get over just my amazement that this actually happens, I guess the first thing I would say is, does it actually happen? Does everyone actually get a colonoscopy? Do you get colonoscopy regardless of your insurance status? Does every wealthy country do it? Is this a terrible problem that we're not doing globally? And if it were hard enough to do it starting at 50 years of age, how big a lift is it to then move it down to 45? Because presumably, since you have to get a colonoscopy every few years, every time you lower the age, you're just massively increasing the number of colonoscopies you have to do.
So the answer to all those questions is yes. So I guess just to take them in turn, we do a reasonable job getting people screened in the United States. For adults in the 50 to 74 age range, something like 2/3 to 3/4 of adults are up to date on colorectal cancer screening. It depends on the specific age range. Older adults do a little bit better. But for that group in the 45 to 49 age range, the latest national data we have suggests that about 1/3 of adults are up to date on screening, so a substantially lower proportion than among those for whom there's been a longer standing screening recommendation. Colonoscopy remains the most commonly used modality in the United States, although I think there's some growing appreciation for stool-based testing. And all of these modalities, so stool-based testing and colonoscopy, are covered by insurance under the Affordable Care Act. And actually, there have been more recent legislative efforts to ensure that not only is the initial test covered, colonoscopy or stool-based testing, but follow-up testing. So for example, if a stool-based test is abnormal, a person will need a follow-up colonoscopy to identify the cause, and that colonoscopy is now also covered without cost sharing. And then lastly, I think there's been growing interest in using other newer modalities. So for example, blood-based testing for colorectal cancer. Blood-based testing has some drawbacks. It does not perform as well as stool-based testing or a colonoscopy, but it may be a reasonable modality to really try to reach that last segment of the population that, for whatever reason, have been hard to reach for colorectal cancer screening with the other kind of more established modalities. So I think we'll see more interest in using alternative modalities like blood-based screening, and hopefully the technology will improve and we'll be able to get to that last quarter or so of the population that's been hard to reach for colorectal cancer screening.
And I just want to point out that the US is really unique in this regard, right? Where colonoscopy is the predominant way that we're screening patients for colorectal cancer, and that the age at which to start for average risk people is 45. In most of the rest of the world, including most of Europe and a lot of parts of Asia, the screening age starts at age 50 still. And the predominant way that screening occurs is through stool-based home tests. So the US is really an outlier in that regard. But what's also interesting is the differing rates of rise of young onset cancers across the globe, where the highest and steepest rates of rise do seem to be seen in more westernized, higher socioeconomic status populations. And so I think that gives us a clue as well as to what might be causing the increases in colorectal cancer, especially in younger people.
Okay. So colonoscopy has been revolutionary for the management of colorectal cancer in the main cohort of people who get colorectal cancer, people in their 50s, 60s, and 70s. You're moving it down to 45. What those young people that get colorectal cancer is moving to 45. Is that a pragmatic compromise, or is that totally nailing the problem? Like, if you really wanted to offer to people between the age of 20 and 50 the same protection as we're now trying to put in place at the public health level for older people, would we have had to have gone to start getting your first colonoscopy at 20 years of age? Congratulations, you got into college. First term, we're going to do a colon. I mean, or is that totally ridiculous? Or can we rely on? I see all these TV. I think even at the Super Bowl, there was an ad for these simple tests for testing for blood in your stool. Is that a poor man's sort of second follow-up, or is that actually a great thing to do?
I mean, I think, and Ilana can probably add more background to this, but I think it was controversial to even lower to 45. I do think that the vast majority of patients with colorectal cancer are diagnosed in their 40s. So I do think that moving the age down to 45 will indeed prevent a lot more cancers in young people, as well as detect them earlier. But to your point, the steepest rates of rise are actually among the very youngest patients in their 20s and 30s. And this is true for many other different types of cancers that are rising in young people. And those folks remain ineligible for screening. I don't think it's likely that the screening age will be lowered any more than 45 just because of logistical considerations, capacity considerations, financial considerations. But I do think it's really important to maybe adopt a precision prevention strategy where you identify the young people who have the risk factors, who are at high risk of developing young onset cancer, and you target those individuals for earlier screening.
I agree. I'll just add that for any screening test or preventive intervention, the benefit is always proportional to the absolute risk. And so even though we're talking about these rising rates among younger adults, the absolute risk happily still remains low, substantially lower than what we see among older adults. And by the time you get into your 20s and early 30s, most people have very low risk. So, of course, there's a subset of people who may have hereditary conditions or other medical conditions that put them at elevated risk. But in general, fortunately, those are groups that are at low risk.
If this literature, much of it is just being generated now or is quite contemporary, are we anywhere close to actually having at the population health level a comprehensive rollout of sort of precision targeted advice and counseling to young people? I mean, is the average primary care physician working in some big healthcare system in the United States seeing a 25-year-old and able to get some smart prompt in the EHR that says, aha, this patient has a family history of X, or so please recommend the following? Do we have anything like that, or is that still somewhat aspirational?
I don't think we're quite there yet. And, knowing who is at high risk implies that we know what the risk factors are, and we actually don't yet. So I do think that a lot more research does need to be done before we get there. And there is an algorithm to identify those who would benefit from earlier screening.
I'll just add that from a primary care standpoint, there's a trade-off between complexity and, precision, and then the ability to effectively implement something. And we see this even in lung cancer screening, which has just criteria that are like ever so slightly complicated. And we've had such a hard time implementing it for a variety of reasons. But I think the complexity of the criteria, which are not actually even that complicated, is part of it.
Implementing any change in healthcare is always a huge lift. And it's not as if primary care physicians are even having that many conversations with 25-year-olds.
Right.
Yeah, it's true.
25-year-olds don't have a primary care physician. So just before we get off the prevention and start getting to what do you do if you think something is wrong, can you just tell me about these home stool tests? Where are we with those? So I work in intensive care, and in intensive care, everyone's stool has a little blood in it. We've been instrumenting people. We've been putting NG tubes down. They're often have impaired coagulation, etc. But out in the general public, how useful are those tests, and how often should they be done? How are we currently thinking about using them?
From a primary care standpoint, stool-based testing has many advantages. First, the data are good. Stool-based tests were some of the first kinds of colorectal cancer screen to have really compelling trial data to show that they reduce the risk of dying of colorectal cancer. So we have excellent data. And then the technology has improved over the years, going from a guaiac-based assay to fecal immunochemistry and now FIT DNA. They have different advantages and disadvantages in terms of sensitivity and specificity. There are different cutoffs for calling a positive test. There's a lot of nuance around it, but the bottom line is they are reliable. We think they're effective, and they're very easy to use in primary care, which is a tremendous advantage. You can order the test. It's sent directly to a patient's house. They return it in the mail, and you're done. And they are good between 1 and 3 years, depending on the test.
No, I was just going to say I completely agree. And especially for the young patients presenting with colorectal cancer, it has a lot of potential to be used as a screening exam because the predominant type of colorectal cancer that's rising in young people are left-sided cancers. So these are the descending colon, sigmoid colon, and rectum cancers, and they often present with blood in the stool. And so this is potentially a very good way to screen, but it hasn't been studied at that population level yet to see if it would be an effective strategy. But I agree, there is a lot to be said for stool-based home testing.
And so the way it works, it's basically looking for blood. And so if you did the test and you had blood, does it mean you have cancer? Putting aside the false positives, or could it just mean that it's picking up like a little adenoma or a polyp, which is also useful to know about and remove?
Yeah, both are true. So the test can pick up early stage or late stage, but it also can find precancerous polyps. So the sensitivity is around 40% for stool-based testing, again, depending on the product, which is worse than colonoscopy, but better than blood-based testing.
Yeah, so cancers are more likely to bleed than polyps, right? And that's why stool-based screening tests are better at early detection of cancers that are already there than cancer prevention. But again, in order for a stool-based test to work, you have to have that follow-up colonoscopy, which then can detect polyps and remove them if they are there and enable cancer prevention. So it is still a very useful screening test.
So we know rates are rising. We think there are environmental factors at play, and we have several screening options. But what should patients and their doctors be looking for? For the final segment of our conversation, I wanted to understand exactly which warning signs should not be ignored and which treatment options are available.
Yeah, so the most common presenting symptom for young patients with colorectal cancer is indeed seeing blood in the stool. Also, abdominal pain or pelvic discomfort or bloating is the second most common presenting symptom. But other red flag symptoms include a change in the caliber of the stool. So, for example, if your stool starts looking thinner and they're pencil thin, that could be a warning sign. If you have changing bowel habits, new constipation, new diarrhea, that could be another sign. And then unintentional weight loss, as well as anemia, which can also result in shortness of breath with exertion or fatigue with exertion, is also a very common sign and symptom for patients who end up being diagnosed with colorectal cancer. But, delayed diagnosis is a real problem for all young patients with all types of cancers, where, as you mentioned, many of them don't have primary care doctors. They're not regularly seeing somebody in the medical system to talk to about symptoms. And there's also a lack of awareness because they're otherwise healthy and there's no family history or risk factors that cancer can be possible. So delayed diagnosis is a big factor in why so many young patients with all types of cancers present at more advanced stages of cancer, which carry a much worse prognosis and are much less likely to be cured.
I'll add that from a primary care standpoint, this is so challenging because GI type complaints are really common, right? So bloating, diarrhea, constipation, all these things are just a daily conversation. And do we send every single patient who comes in with these symptoms for a colonoscopy? When I was in medical school, which was now a couple years ago, but not that long ago, we could, I think, feel pretty reassured for patients in their 20s and 30s. Like, it's very unlikely to be colorectal cancer, but the age at which we start to get concerned has dropped. And so it's really, really challenging. And going on symptoms alone, we have red flag symptoms, but it's very hard to ever feel totally reassured when people come in with new symptoms.
I always say I do not envy the job of a primary care physician. It is so hard and so challenging to know when to act and when to order a workup because these symptoms are so nonspecific and statistically probably more likely to be due to something benign.
Yeah. One thing I learned recently is that in the UK, the clinical guidelines suggest using stool-based testing, stool fit testing as a way to triage, which is not the way that we practice here. And in fact, we're always taught never to order those kind of tests in somebody who's symptomatic. But it was just thought it was really intriguing. Like maybe there are better ways to triage patients who are coming in with these nonspecific GI type concerns.
And presumably history can help a little bit. So if someone comes in and says they've had a change in, like they've started to become constipated, and it turns out that they just changed their diet, or they've been on some vacation somewhere and had, the act of traveling, and they say, yeah, every time I travel, I get all bunged up. You go, okay, well, that's not quite as serious as, no, I was just doing everything that I do normally. I didn't change my diet. I wasn't traveling. Just suddenly yeah, that does seem challenging. So then let's finally just talk about treatment. So at the start of this podcast, we were talking about how I think for a lot of cancers, there's been a lot of improvement in the treatments that we have. Either the treatments yield better outcomes, or we can give treatments that are less unpleasant for the same outcomes. But we also often think that cancers are more aggressive in younger people. I don't know if that's true. It's easy for me to recount the sort of the general old wives' tales that dissipate down to those of us who are not experts in cancer care. But look, if we stay with colorectal cancer, what does the panoply of treatment look like? And how importantly different is it between someone presenting early versus late?
This is a question we're really working hard to answer, but in general, I was part of an international consensus guidelines group to determine how best to treat young patients with colorectal cancer. And the answer in regards to medical therapy, including chemotherapy, surgery, radiation, is that the treatment is exactly the same as somebody who is 75, because we haven't yet pinpointed what the biological differences, if there are any, are in younger patients versus older patients. Now, that being said, younger patients tend to get treated more aggressively. They themselves want more aggressive treatment. I think us oncologists tend to treat them more aggressively as well. So young patients get more aggressive combination chemotherapy regimens. They undergo surgery more often. They get more radiation. In many studies, their survival is not correspondingly better than an older patient. And this is despite tolerating treatment better and having higher treatment dose intensity. Their outcomes are not that different. So that does give us a clue and leads us to believe that younger patients do have more biologically aggressive tumors, or they may be less responsive to treatment. And we are now trying to understand what those distinctions might be.
So some of the biggest changes in treatment for a variety of cancers that we hear about are, for example, the transformative power of some of the immunotherapy that has revolutionized care of tumors like metastatic melanoma, things that used to have terrible prognosis. And now with nivolumab or Yervoy, you can take someone with kilograms of metastatic tumor and you're effectively harnessing the power of the patient's own immune system. And it's really remarkable, some of those stories. Are some of these cancers that people are getting in their 20s and 30s and 40s, are any of those the cancers that have also experienced revolutions in treatment, or are we still talking about traditional chemotherapy, radiotherapy, and surgical resection?
Yeah, so I can speak briefly about colorectal cancer. Immunotherapy has been revolutionary for a very rare subtype of colorectal cancer called MSI high colorectal cancer. That rare subtype is exquisitely sensitive to immunotherapy, where for the first time ever, metastatic MSI high colorectal cancers can actually be cured with immunotherapy approaches. Unfortunately, the vast majority of patients do not have that subtype. And so the most common subtype of colorectal cancer does not really respond at all very well to immunotherapy approaches. So it is an active area of research to try to render this most common subtype responsive to immunotherapy. But right now, it doesn't play a major role for the vast majority of our young and old patients with this disease.
That's depressing. Let me ask another related question. My understanding is that there's been a big movement in recent years, in part because we have an expanded repertoire of anti-cancer therapies, to also leverage advances in imaging to then start to basically say that a lot of people could be managed with an intense surveillance. That because we have high resolution imaging, you can give someone therapy and then you can do very careful watchful waiting. And because you can pick out recrudescence, recurrence of the tumor very easily, you can then immediately pounce in. And again, that's the story one hears. If someone is young with a cancer diagnosis, they're presumably hoping to live for decades. And so is part of the treatment of young people with cancer to also rely on very active vigilance and monitoring after the initial treatment? And are they then subject to years and years of having to go back every year or every couple of years and have everything be rescanned? Is that a feature of the illness?
Yeah, we of course want our young patients to have years and years of survivorship available to them and good quality of life too, because as you know, there can be long-term complications of cancer therapy. But for the most part, the surveillance regimen and schedule for a young patient is very similar to an older patient. That being said, there are advances, not just in imaging, but in ways to detect microscopic amounts of circulating DNA from tumors in the blood of patients with cancer. And that in the future may prove to be a better way to monitor for molecular recurrence and to catch it much earlier. The problem is right now, I think the technology is not quite there yet for us to be able to do this accurately. And if we do find molecular residual disease or evidence of microscopic residual disease, we don't yet know how to intervene on that and whether intervening will actually prolong survival. But I do think that advances in genomics like this and technology have also proven helpful for a lot of young patients with, for example, pancreatic cancer, who tend to have a higher rate of having what we call actionable DNA mutations, where there are targeted therapies that can specifically target that one abnormal protein or mutation. And patients who do get access to targeted therapies do tend to have a better prognosis. So I do hope that as we learn more about the unique biology of young patients with cancer, we will have more targeted therapies specifically for these young patients.
So I think that brings us then to some sort of wrap-up thoughts. Kimmie, you were alluding a little bit to things you were hoping for. We started this podcast by trying to unpack what feels like a pretty scary problem. I think the idea of getting a severe, life-threatening cancer in one's 20s, 30s, or 40s sounds super scary, and you've done a great job to convince us that people are far more likely to have that happen to them now than we did in the past. And we're still not quite sure why. But there have to be some avenues that provide hope or optimism. I wonder if we could maybe wrap with both of you telling me what you think the biggest reasons for optimism are in terms of whether it's diagnosis or treatment or finally, raising awareness. Where do you see that we have a realistic chance for important breakthroughs that are going to bend the curve on this problem?
I think in some ways we've kind of reached this late stage modernity where we're really starting to grapple with the world that we've built for ourselves, right? What does the food we eat, the environment we live in mean for our bodies? And I think that realization is an opportunity to think about how to actually improve health in a really deep and holistic way. And that's been part of the national conversation. So I'm encouraged by that. I also think technology around screening will get better. I think a lot of it is legacy technology that's been useful and has good data to support it. And I think we'll see a lot of innovation. It takes time to understand how effective that innovation is, but we'll see growth in the ways that we can screen. And I hope that that translates into effective screening technologies that are easier to implement.
I completely agree. And, in general, I'm an optimist. I think to be an oncologist, you kind of have to be an optimist. So I do think that with the advent of technology to be able to really understand the molecular basis of these cancers and why they're happening, to our more advanced surveillance systems to estimate environmental exposures, I think the combination of those things, as well as everyone is rallying around this problem, which has gained increasing attention. And so I do hope that it becomes more of a funding priority for people who fund research into cancer. And I do think that with international collaboration and scientists coming together from multiple disciplines, we will make advances in our understanding of why this is happening, as well as how we can better treat our young patients. I think in the meantime, it is still really important to, one, get screened if you're eligible to get screened. Two, it's still important to follow a healthy diet and lifestyle, as Ilana was saying, because even though I mentioned that so many of our patients do and they get diagnosed anyway, it is still really important to follow those healthy habits starting from early childhood. And three, and we didn't really touch on this a lot, but I think many people don't know their family history. And so it is really important for primary care doctors to ask, for people to talk to their family members about whether there is a history of colorectal cancer, for example, or colon polyps, because that could change the age at which you begin screening and could be potentially life-saving.
Well, on that note, it's really been a pleasure to learn so much from both of you. And although this is obviously a huge and concerning problem, I take heart in your optimism about things that are on the horizon. So thank you both for joining me today in our Healthy Dialogue.
Thanks.
Thank you for having me.
And thank you for listening to this episode of Healthy Dialogue, where we've been discussing early-onset cancer with Kimmie Ng and Ilana Richman. To learn more about JAMA Network research on cancer, check out the resources linked in our episode notes. You can also email us questions related to this podcast at healthydialogue@jamanetwork.org. If you'd like to continue today's conversation, please subscribe, rate, and share this podcast. This episode was produced by Daniel Musisi, Matthew O'Connor, and myself at the JAMA Network. Until next time, thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.